Hello, good morning, good afternoon, and good evening to everyone attending today, and welcome to our webinar today on effective, equitable, and efficient sharing of individual level data, recommendations, solutions, and ways forward. Data sharing has been widely touted as critical for an effective evidence-based response to the COVID-19 pandemic. While it has indeed played an important role in some areas, such as the sharing of sequencing data, it has been more limited in others, such as the timely and global sharing of clinical research data. In this webinar, we have some members from the data sharing working group of the COVID-19 Clinical Research Coalition who will report on some of the findings of the research that they have done, primarily funded by WHO. And specifically, their work addresses the needs of researchers in low and middle income countries. And while we understand and are well-versed with all the challenges facing data sharing initiatives, today our focus will be on some of the wonderful work that has been done, some of the solutions, the possible ways moving forward. And we're really looking forward to having a great discussion about how we can move this forward in a productive and in a meaningful way. So we will carry on. Next, please, to talk about this coalition. Now, the coalition was formed in April of 2020 by clinical researchers and scientists in response to their growing concern about the impact of COVID-19 on health systems around the world, and that the COVID-19 related research priorities of low resource settings would not be adequately supported or prioritized. And therefore, you can see that the members' commitment and the coalition, in fact, leverages global expertise to advance high-impact COVID-19 research in low-resource settings, including through its 13 advisory and expert working groups, and the data sharing group is one of them. It advocates the issues of concern to its members. It promotes open sharing of research knowledge and data, and it champions equitable and affordable access to the vaccines, diagnostics, and treatments proven to be effective. If you are interested in joining us or want to learn more, you are most welcome. Look for the links that we'll share in the chat. Next, please. So this morning, I am very happy to be the moderator and to welcome you. My name is Sharon Kaur, and I teach at the Faculty of Law, University of Malaya. We have a number of extremely well-regarded and excellent speakers who are experts in their fields, which I will introduce in a little bit. And we have an exciting agenda. It's jam-packed, so we'll go through it quite quickly. We'll have a quick introduction to the data sharing working group. We'll consider issues of broad consent and some data sharing solutions for international collaborations, as well as the use of data sharing information requirements in registries. We will then have some time for the Q&A, which is possibly the most important things. And then we will also have some closing remarks. So just a few housekeeping details. Next, please. The webinar is being recorded, and a link to the recording will be published soon. Please ask questions via the Q&A tool, and you can upvote questions by clicking the thumbs up icon, which will send these questions higher up on the list. And if you would like to address a question to one of the speakers in particular, please be sure to include the speaker's name with your question, and we will ask you to fill out a short survey when you leave this event, and we thank you for your feedback on this webinar. Next, please. So in order to not waste too much time, I'm just going to go straight to the first speaker, Professor Pek Yong Chia, who is a bioethicist and professor of global health at the University of Oxford. She heads the bioethics and engagement team at the Mahidol Oxford Tropical Medicine Research Unit in Thailand, and chairs the COVID-19 Clinical Research Coalition's Data Sharing Working Group. So Pek Yong, over to you.
Hi, thank you, Sharon. Thank you very much, and welcome to this webinar. I'm Pek Yong, a bioethicist at Moru and based in Thailand normally. I'm the chair of the Data Sharing Working Group, and today I'll be presenting on behalf of the group. So there has been a greater call by funders and journals for more data sharing for about a decade now. But in reality, the volume of data shared remains lower than hoped, even with COVID. But we are trying to change this. The overarching aim of this working group is to facilitate and promote effective, ethical, and equitable data sharing for COVID and more generally. The 3 E's here are carefully chosen words. What do we mean by effective, ethical, and equitable? We hope to promote the greatest use possible of the data generated to help with the management of the pandemic. i.e., we want to maximize the use of the data and maximize its benefits. But we also want to protect the interests of study participants, their communities, and researchers who generate the data, and at the same time, mitigate any harms that this might arise. So what have we been up to as a group? Many things, but today we are going to report on a project funded by WHO and a few affiliated projects funded by other funders. I will mention the objectives of this project briefly here. To map out the current practices on data sharing, this is through a literature review. To map out the compliance to data sharing policies by authors and journals. To characterize data sharing requirements and practices across trial registries, and to understand the concerns around broad consent for future use. We hope that these projects will provide us some insights so that we can work on potential solutions to promote data sharing in an equitable and efficient way. You will hear about some of this work today and some complementary projects. I'd also like to mention this project, which is partially funded by the same grant. This project actually started prior to COVID to develop a data sharing learning framework and to pilot some modules related to data sharing. One of the things we did was a needs assessment. One of the main reasons for lack of sharing is because researchers don't know where to share data, how to share data, and let's say what wording to put in the information sheet, some practical things. So training and capacity building is necessary. This course, and you'll see the link here, is aimed at early career researchers, postgraduate students and clinical trial research support staff who are collecting and managing and using data. It's not designed to train data managers and statisticians, although they might be useful. There are currently 5 modules on the website here. These are written and peer reviewed by members of the working group. They are free and you can download a certificate. The modules are on the slide here: Intro to Data Management, 2 modules in Ethics, a brief and longer version, Data Governance, Policies and Data Access Committees, and Data Quality. These are our working group members. They are from all over the world. They're researchers working on ethics, regulatory and data management, and operational aspects of data sharing, many of whom have collected and shared data. We have a wide range of experience. So this is my final slide. I leave this slide with the publications for your reference. That's all from me. Thank you very much.
Thank you very much, Pek Yong, for that introduction. Our second speaker today is Dr. Maria Consuelo Miranda, who currently works as a WHO consultant at focal point of WHO's Solidarity Trials in the Amro and Paho region. She has previously held positions in CDM, Sanofi, and academia, where she was involved in various infectious disease research projects in various capacities. And today she'll speak to us about broad consent for future use, a qualitative study of ERC members' attitudes towards data and sample sharing in Colombia. Over to you, Maria.
Thank you, Sharon, for your kind introduction. I'm going to present this qualitative study related to the perspective that the members of the Ethics Committee in Colombia had about the challenges for the ethical implementation of broad consent for future use of data and samples from human subject research. Next, please. Why share data? As mentioned by Pike, data sharing can facilitate reproducibility and trust in the research process and in research outputs, enhancing transparency and validity of the research. In terms of the research translation, data sharing can build cross-national and cross-discipline networks which can accelerate discovery and innovation. For example, accelerate the drug or vaccine development, as well as advances in clinical practice during and outside of the epidemic response. Ethical imperative. This is an ethical imperative to maximize utility of the data. Data sharing can save lives through efficient and effective research public health response. Prevention of unnecessary research, conserve limited resources through the prevention of redundancies. Next, please. It has been agreed that the definition of the broad consent for future use is research participants' consent for reuse of data and or samples collected by researchers who may not be affiliated with the original study team for purposes that may differ from the objectives of the original study. Other characteristics is that the participants who provide broad consent are not recontacted when their data or samples are used in additional studies. Broad consent for future use must meet the SIOMS criteria, especially the appropriate governance, and the data sharing must not adversely affect the rights and welfare of the research participants. Next, please. It is a qualitative study where individual, semi-structured, in-depth interviews were carried out by video call conference in order to understand the ERC members' concerns when evaluating research protocols that include broad consent for future use. Some topics were established for the analysis using deductive and inductive calls. The data was analyzed in the MES-QDA software, and 24 interviews with ERC members were conducted from February to May 20 to 21. Next, please. I would like to mention some representative responses to the concerns of the ERC members within the main topics analyzed. Regarding the mistrust, fear, concern about the future use, the consent forms are not sufficiently clear so that a person with a level of education that the participant is expected to be can read it and know what is happening. The rights of people must be respected, consent must be well formulated. Other members said, something that I will not approve is to leave the broad consent, informed consent like a blank check. And another member said, who safeguards the information? Who is in charge of defining that this sample lives or does or no for the investigation? Who administer and safeguard the information? Another is a defined area, a boundary, at least mention a subject area, or at least the disease, defining the disease. No, that's something that remains open. Next, please. Regarding the concern about the beneficiary, there are these samples. We also want to avoid this use of samples in Latin America to do extractive research. That is Latin America as a sample dispenser only. And another phrase to mention is that I think that is very well marked, how to be honest with the volunteers about where the focus is going, and that the volunteer also has the ability to define if he wants that benefits or no. Regarding to the community involvement, this pandemic has exposed the need to do research, has shown the little knowledge that people should be involved in an educational process that allows them to participate in decision making in regards to the generation of knowledge, precisely through that where they live, the problems they have, or what happened with the resources they provide, such as their samples. Next, please. Regarding the data as a public good, the pandemic has shown everybody that this is not local or regional or mine. The knowledge is not mine. In fact, it belongs to everyone. We all have to put this together. I believe this is one of the things we have learned from the pandemic. But as ERC members, we always have a connotation that I'm going to export the samples from my people, my data, my samples from our area, from our country, from our region. Next, please. Here we can see a summary of the main concerns of ERC members in terms of an approval of a request for broad consent for future use that would warrant that elements that, if present, almost facilitate the approval of broad consents. This is mentioned about the arrow the right direction above. For example, use by academic institutions, the benefits to society, research participants or researchers. And below we can see that according with their evaluation, they would not approve a broad consent. For example, the commercial use. This is well market. Next, please. This is the conclusion. The ERC members are concerned about the broad consent for future use and benefit sharing. They suggested the following to help address their concern: the pre-specification of reuse purpose, the clarification of the governance framework, the clarification, the ensuring participants understand broad consent for future use related language, and engaging of the community in the setting public health priorities for data reuse. Next, please. This is the project team. Laura Maswell from the University of Heidelberg, that as well is part of the working group, sharing data working group, and Luz Liguestra from the University of Heidelberg, Jacqueline Bravo, Universidad Industrial de Santander, and Infovida. Deyanira Duque, she's from MinCiencias, the Ministry of Science and Innovation of Colombia. And I would like to give special thank yous for the supporters. This project has been co-financed, co-funded by the program RECODIT, that is the reconciliation of the cohort data from infectious diseases. And this has been funded by the European Commission and for the Canadian Institute of Hall of Research, the Genetic Institute. And also a special thank you for TDR program, the special program for research and training in tropical disease for the WHO. And thank you for your attention.
Thank you so much, Maria. That was perfect timing. And thank you for these valuable insights into the thinking of ethics research committees and the importance of addressing broad consent in a meaningful way when we think about data sharing. Our third speaker is Ms. Laura Merson, who is the head of data at the International Severe Acute Respiratory and Emerging Infectious Consortium, as well as the Associate Director of the Infectious Disease Data Observatory. She's based at the University of Oxford and oversees both ISARIC's and EDO's strategy and operations related to the standardization, collection, governance, and analysis of global data in epidemics and pandemics. Today, Laura will talk to us about accelerating science in public health emergencies, data sharing solutions for international collaboration. Over to you, Laura.
Thank you, Sharon, and thanks everybody for having me today to explain some of the solutions that we've found that have helped to accelerate science over the last few years. So, more than ever before, COVID-19 has shown us that sharing data on emerging infections is critical to an effective and efficient outbreak response. And this global recognition, combined with recent technical advances, has led to outstanding examples of how data can accelerate response. For example, publishing viral sequences has enabled the record-breaking vaccine development that we've seen recently, and has also allowed us to track genetic variants to understand differences in disease progression and transmission. And making global epidemiological data available has helped governments to track and prepare for spreading cases. But access to clinical data has not kept pace with this trend. And we all know that clinical data is absolutely critical to characterize new diseases, to understand how they work, who they impact, and how to treat them. And it's not just data from the higher income countries that we're seeing so much more of during this COVID pandemic, but it's data from all over the world, because we need to generate evidence that's representative of everyone who is impacted by this disease and future diseases, so that we can find solutions for everyone who is impacted. And so what I think we need to leverage data sharing to accelerate science and be able to bring together all of the global data, ideally to a centralized or a group of centralized places where those data can be integrated and made available for safe, secure, and ethical reuse by those who need it to find solutions for a pandemic. And that's health authorities, that's researchers, regulators, policymakers, and others all need rapid access to data in order to be able to have an evidence-based public health messaging and policies, and also to produce papers, publications, treatment guidelines so that we can respond to a pandemic. And so we decided to do this. Building on the Infectious Diseases Data Observatory existing data sharing platforms for other diseases, we partnered with ISARIC and with hundreds of sites around the world. We have more than 64 countries participating to centralize data into a single platform that's hosted by EDO. Now, this platform today has data on more than 800,000 hospitalized individuals with COVID-19. And those data are made available through a robust governance and ethics framework to the authorities, researchers, policymakers who need them to find solutions to the outbreak. Now, we have had we have had 100% of these data be reused, and they've been reused for 52 novel analyses to date. And we accept new applications for access to data anytime, and you are all welcome to of course, get in touch and apply. And those data have been used for these new analysis to generate reports and live dashboards, to publish peer-reviewed papers, to contribute to national statistics, and also to help drive government policy. But there have been challenges along the way, and I'm sure many of you are familiar with the challenges of sharing data, even aggregating it and then making it useful, and then of course sharing it externally. And it's those on the right with respect to external sharing that I want to focus on today and share with you some of the solutions that we have found to researcher concerns about misinterpretation of data or low quality science, the need for reciprocity in data sharing, and the worries about inequity in data reuse. So one of the solutions that we have developed is to involve those who collect the data in the secondary analyses. And the main way to have them involved is, of course, to invite them to use the larger collection of data that has been aggregated and to suggest and lead analyses. And what this does is make sure that the evidence that's generated from the platform is locally relevant and is informed by the various researchers around the world who are seeing patients firsthand. And it ensures that we promote collaboration and provides a really robust review process from all of the people who collected the data to contribute to that science. So that really improves the quality of the science that is generated. And this addresses each of those concerns. It removes the chance of misinterpretation of data because those who collect it are involved, really augments the quality of science, so removes any concerns about that. There's reciprocity that's built into this because there's involvement in generating the evidence that is relevant to the patients from whom those data come. And of course, it addresses inequality because everyone gets involved. And then even more so with respect to inequality, we look to find solutions to providing academic accreditation for the sharing of data and the reuse of data. And I'd like to tell you how we're doing this, which I think is quite new and groundbreaking. So it's a new initiative of ours. What we do is we label all of the data sets with a persistent identifier. So we use DOIs as that identifier. So every data set contributed to the platform gets its own DOI. And linked to those DOIs in the metadata in the background are information about the people who collect and generate those data. So the ORC ID of all of those researchers and research nurses and data managers who do that collection, those are linked on the back end of that DOI. So then anyone who uses that data set would cite the DOI, which is then tracked back to those who created the data set. So it's a cycle of driving academic metrics within data reuse. And these metrics are all sort of aggregated and managed by a group called DataCite, which you can then troll, and funders can go and look and see how often you have shared data and see how often your data have been reused. So that's a novel way of augmenting metrics for data sharing. And so this addresses concerns about reciprocity and also inequity. And so how do we effectively leverage data sharing to accelerate pandemic response, or actually science for any health condition? Well, we promote equitable and robust data use. So by implementing these equitable approaches, we build collaborations that we can accelerate science. We strengthen the integrity of the research that we're generating, that we make sure that the evidence generated from those data are relevant to the populations from where the data comes. And that means that the treatments and solutions that come out of those different analyses will benefit those patients directly. And so it also returns benefits to those who generate the data by academic accreditation or involvement in new research. And lastly, it encourages further data sharing because everyone sees that this system works and wants to be a part of it, and that therefore amplifies the impact of any data that's generated. So we welcome all of you to find out more about what it is that we're doing and to contribute data or access data from this platform and the other platforms that EDO runs at our website that's on the slide. Thanks so much for having me today.
Thanks, Laura, for that fantastic presentation and the great initiative that you're leading at EDO. It sounds amazing, and certainly the way forward in promoting equitable, robust data use, which is what we really need. Our fourth speaker today is Dr. Duduzile Nwandewe, who is a vaccinologist at the Cochrane, South Africa, and is a project leader for the Clinical Trials Registry portfolio. Her previous work has been on implementing various HIV prevention clinical trials in South Africa, and she currently engages with critical stakeholders nationally as well as regionally in an effort to promote the transparency of evidence generated in the conduct of clinical trials. Over to you, Dudu.
Thank you so much, Sharon, for the warm, for the great introduction. So colleagues, today I'll be talking about the requirements of data sharing in the ICTRP registry. So this is my overview, just a second. So this is my overview of the presentation. And as a way of introduction, and my colleagues have also elaborated on some of these principles in terms of data sharing, but really just to emphasize that clinical trial data sharing has principles surrounding it that we need to abide into, and some of my colleagues have touched on those. So our project, we wanted to build an evidence base in the contents of the individual participant data sharing field within the ICTRP. ICTRP is a one-stop shop portal where all registries across the world sends information so that researchers can be able to access the registries, the registry information there. And what we did, we analyzed how do they differ? How this data is, when it's collected, how does it differ across time, economic, geographic region, and disease relevance, and also the type of sponsors and the funders? How is it different in terms of collecting that data? These are the methods that we have used. We collected the data straight from ICTRP platform. We coded the data through by using the codes, the economic status, geographic region, the disease conditions, and the funder and the sponsor type. So there was a lot of coding that was involved. And we conducted some descriptive analysis, which I'll share in a bit of what we found. And the table here just shows the number of registries that we had to use the data from. So this is just a snapshot of the number of records that we looked at. We had over 600,000 records that we had analyzed, and we focused mainly on the data sharing, which is item number 4, what is listed in the ICTRP. It's item number 24. We focused on that field. And what we eventually included in our analysis after removing duplicates was we ended up having about 500,000, almost 600,000 records that we had to go through. And we also conducted some analysis on the years 2019 and 2020, and you'll see why we did that as we go along. So this slide, what I'm trying to show you is that over the years before 2005 towards 2017, when there was a need of introducing this item number 24, and towards 2019, you see that the records are slowly improving in terms of capturing information on the IPD sharing plans that registries need to collect. So that's basically what I'm trying to show in this slide. Although you still see some registries or some records that still say no, yes, they would complete the IPD sharing plans or complete that information, but they would say no, they would not want to share, and we'll go into much detail of what we found. And what we also did was to analyze economic and geographic regions. And what we see is that studies that are recruiting in high-income countries and low-income countries indicated that, yes, they would want to share IPD. However, when you look also in the geographic region, studies from North America were indicating, no, they would not want to share their IPD sharing plans. But again, what you see is that studies conducted in sub-Saharan Africa, majority of them had their plans, they wanted to share IPD. And then studies that are recruiting in high income countries, then you see most of them are saying, no, we would not like to share IPD. And when you look at the registries that we looked at, majority of the records were coming from clinicaltrial.gov, and there's a huge distribution and a variable distribution of the IPD sharing plans across registries. And if you look at the block of the sizes, the number of records within those registries. And what we see here is that the intention to share IPD, it varies again amongst the registries, where you see that, and it corroborates with the statement of sub-Saharan studies wanting to share data, where we have the Pan-African Clinical Trial Registry, which is a registry that caters for all African trials. It's sitting at about 90%, which is really encouraging to see. Other registries are still sitting a little bit below in terms of wanting to share their IPD plans. And when we looked at the funders and the sponsors, and we grouped them according to a commercial sponsor or a non-commercial sponsor, and what we see, there isn't really much of a difference in terms of whether there is a change in terms of the pattern in wanting to share or not to share. And when you look at pathogens of concerns, we also looked at the WHO priority disease list, and we focus mainly on the diseases from 2015 to 2020 and compare that with other conditions. And what we find was that there's a slight shift in that period of wanting to share IPD. However, when we looked at 2020, looking particularly for COVID-19, you see that there isn't that much of a difference in terms of the intention to share IPD. Some of the take-home messages from this work is that we can use the registries as a source to enhance, or as a tool to enhance transparency and help us to realize the scientific potential to access IPD information on these clinical trials. And we see that there's variability across the registries in terms of the economic status or even the funder. There's just some variability. And what we noted was that whether there's a public health emergency, we still remained at about 14%. And what we see, what is encouraging from this data, is that sub-Saharan studies are really wanting to share their IPD. Perhaps it's something that we can learn from. Again, there is similarities whether the funder or the sponsor is the same, or it's a commercial or non-commercial. So the IPD, the intention or the willingness to share IPD, it's similar. There are research gaps, however, when you look at the economic status and also looking at the economic status, it's quite interesting to see that, you know, the high income countries as well as low income, the studies that are conducted in those two regions, there's high willingness to share IPD. What is it? What makes them want to do that? Maybe we can unpack that a little bit. And also, what is happening with the low and middle income country that we can learn from? And some of the call for action that we would like to put up is that we need to understand the factors that impact the investigators' ability to be willing to share IPD and maybe start to build from there. So in conclusion, is that the ICTRP is a source of clinical trial transparency. And we need to improve the quality and the completion and standardization in the registry so that it can cut across and the data can be reused. And also we need to establish mechanisms in which we can protect the interest of the researchers conducting these studies. And also ensuring that everyone has the full benefit of using this data. Funder and sponsors have equal responsibilities as well to promote IPD sharing and increase the availability thereof. So with the last slide, I would like to acknowledge our funders, our organization, and most importantly, our project team that really made this work possible. Thank you so much.
Thank you so much, Dudu, for that really, really interesting study. And I think I really look forward to hearing you unpack some of your results in the Q&A session. So we're really doing well for time. I think everyone's really kept to time. So we're now going to move into the discussion and Q&A session. I would like to invite all the speakers to turn on their video cameras so that they can take part in it. And at this point, we are joined by Dr. Robert Terry, who is the Manager of Research Policy in the World Health Organization's Special Program for Research and Training in Tropical Diseases, where he is responsible for knowledge management, open access, data sharing, and ensuring evidence is translated into policy and practice. So welcome, Rob, to the panel. Just a quick reminder on housekeeping. Please remember to use the Q&A tool at the bottom of the screen to ask questions. You can also upvote the questions. We have a couple of questions that have been upvoted a little. And if you would like to address a question to one of the speakers in particular, please be sure to include the speaker's name with your question. So I'm just going to go straight into it. I'm going to address questions to specific people, but I think it would be nice if we tried to keep it quite informal. So if anybody, feels like they want to add on to anything or you want to say something, please just raise your hand or just shout very loudly if I don't see you, and we can have a nice chat. So the first question is for Maria. What are the ethical concerns in broad consent? And are participants from LMICs at a particular disadvantage regarding broad consent? Over to you. Maria, you're still muted. We can't hear you.
I could say that yes, they do have disadvantage. In Colombia, like in several Latin American countries, and also as well in low and middle income countries, there is no regulation on data sharing, and there is no regulation on biobank or biorepositories from research human subjects. This is put on the shoulders of the ethics committee, all the decision to share data, to export data, to export samples, and sometimes is overwhelmed this decision because the decision didn't have a background or base a regulation. Yes, you have to do that. You have to, and in that direction, to protect the rights and the autonomy and the welfare of the participants. This and the other thing that is important to mention, that is the educational level of the people, and even in educational level, the language is a complex language. When you explain about the biorepositories and the biobank and the governance and all these concepts are really difficult to explain to the subjects, and this is just a section of the informing consent form of all the when you collected the samples in the primary study. It is difficult to explain all the research, the vaccine research, on the drugs or in other. It's difficult to explain. So this section is put just you have to mark if you accept to share data or to send data to other countries, or no, but no, it is not usually to use the data. It's just for the samples. Yes, and we have in the past several studies that just avoid to share samples, but they didn't talk about the data. So I think in that, yes, I think yes.
Thanks. Yeah, so that's really quite insightful, the need for maybe more robust regulatory frameworks and governance frameworks, as well as more educational materials.
Yes.
So Pek Yong, I'm just going to pivot to you and ask you about what you think about this particular question from perhaps a more Southeast Asian perspective, based on the work that you do at Moru. Over. You are also still muted.
I think, thanks, Sharon. So one of the things is, as Maria Consuelo said, is understanding what broad consent means. But so what we're trying to do at the moment is to try and have quite a bit of consultation with our local communities whenever there's a big project, so that we can get information or get some suggestions on how to word it. I think it's really helpful to get the community members or leaders to help us with wording of the information sheet, that use words that are understandable to the community. And we can do this, and we have done this by our own community advisory boards, engaging with communities in many different ways. But one of the ways is getting community advisory board members to have a look at the information sheet. Thanks.
Thanks, Pek Yong. Our second question, maybe I'll ask Laura if you feel like taking this. How can low resource settings best be empowered to own their data and make decisions on how their data will be used?
Thanks, Sharon. Yeah, happy to give some ideas on that. I would say, first of all, for these researchers to share their data in a platform or repository that prioritizes equity. So that has a governance model that makes sure that equity is a driver of the design of how that platform works. And so one of the key things of that is to make sure that that site retains, we could say ownership, depending who owns data, but maybe I would call it control and decision-making power over those data. So I think that the researchers who generate data should continue to retain decision-making power always, and to find a platform in which they can be involved in the reuse of those data, they can be accredited for the reuse of those data, they can have a role in analyzing and accessing other data that are within that repository. So I think it's about making good decisions about where data are shared and finding that right repository.
Thanks, Laura. That's really helpful. And I'm just wondering, what do you think a coalition like ours could do in order to further this sort of ability of researchers to do that?
I guess it's in making sure that researchers have information about what repositories are out there and what the differences are between them. And I know that this working group and its members have done some work to enable tools that show which repositories are fair, in that the findable, accessible, interoperable, and reusable, and also how those different repositories work, and tools for researchers to make decisions about which one to use.
Yeah, thanks. So there's still a huge amount of information that perhaps still needs to be curated for researchers in order for them to know where to go and how to do it. Dudu, the next one is for you, from Rob Johnson, asking if there are any specific pieces of legislation or international conventions that you think need to be revisited in the light of the COVID-19 pandemic to make clinical data sharing easier. For example, the GDPR in the EU or the Nagoya Protocol. Do you think that the lack of regulation or restrictive regulations are one of the reasons why you've seen some of these trends in the registries that you've looked at? Over.
Yeah, thank you so much, Sharon. Definitely, I think we need some regulation and some guidance on how can we promote data sharing? And it touches on the point of the capacity building, because it has to start there. And when we look at the registries themselves, sometimes a registry is seen as a tick box. This is something that I have to do so that I can start with my child, but not fully understanding the benefit of why do you need to share the data? What is the benefit of reusing that data and learning from the data that is already out there? So we need all hands on deck, really, to promote data sharing, and in fact, even promoting registry use to share IPD.
Right, thank you.
Sharon,
Maria? Yes.
Do you mind if I just
please.
add a comment about that? Because Rod specifically mentioned GDPR. I think it's worth noting that governments and regions who put in place restrictive data sharing measures, it's their populations who suffer, because that restricts the reuse of the data from their own regions. And so those patients are less represented in the global evidence that gets generated because there's limitations and restrictions. And then further, that creates a feeling of inequity, because it's possible to use, let's call it European data under GDPR within Europe, but then you can't export that to many other countries. And while we would expect sharing to be a two-way process, we would expect that if you can share data into the EU, you should also be able to share it out. So I think that needs to be reconsidered.
Oh, that's a brilliant point. So some policy work also remains to be done. So Maria, I'm going to ask you the next question about community trust, because that's one of the issues that you raised in relation to broad consent. How can community trust be further built between researchers and the community? What can researchers do over?
I wanted to talk about our work package in Recodit, that is to identify the barriers for sharing data. And there are several stakeholders, and the principals in our view has been the researchers, of course, the participants, and the ethics committee members. We have for each one a kind of project to identify the barriers, and we are conducting a project in special with the participants in research, to try to understand. It's a mixed study with the cognitive interviews, and to try to understand how they understand this language, the normal language that they had received in the cohorts that they participated, and also the thing that they how they feel to sharing data, what is their opinion, their thoughts about we can take your data and your samples and sharing with to improve the knowledge, and we identified several things that we have to improve as a researcher, to improve the language, to improve the connection with the participants in research. That is to give to empower them. That is, they have the power to decide on your body, your samples, your data.
Yeah, thanks, Maria. And I think that also harks back to Pek Yong's point about the importance of community engagement. Do you have anything to add to that, Pek Yong?
No. I'll be repeating myself, so let's move on maybe.
Yeah, okay. So this one's for Laura as well. How many requests on average are processed annually? Is ISERIC tracking outputs from data reuse? Are there use cases that show data reuse is influencing treatment or improving control of COVID-19? That's a great question.
So I mentioned that since the beginning of the COVID-19 outbreak, we've had 52 requests and approved reuses of that aggregate data set for COVID-19. So that's over the last almost 2 years now. And that is one of the highest levels of reuse that we've ever seen with any of our diseases that we're covering. We do track these, and we have right now just very summary level metrics, which we hope to expand sometime soon within the EDO website. And with respect to reuse and the impact of this, I think it's quite easy to track the academic metrics, and you can see how many papers have come out and how many times the data sets have been reused. And it's much more difficult to track the policy impact of all of that data reuse. And so no, we haven't figured out a way to do that effectively yet. These data are being used across so many different countries in so many different ways. We have a direct link with the WHO, so we get feedback from them on what they use. But within all the departments of health, ministries of health, we don't know. And very happy to have support in developing that further.
Fantastic, new opportunities. Okay, so one last question before I hand over to Rob, and this is to Dudu. Oh, but it's vanished. I was going to ask about the very high level of misinformation we've seen during the COVID-19 pandemic. How can we ensure that more misleading information is derived? I don't know if it means that not more misleading information is derived from analysis of IPD if made available broadly for secondary purposes.
That's a good question. But I think what is important is really understanding what the secondary data is going to be used for. That's number one. Number two, citing the original data set, then that eliminates the reuse, misinterpretation of that data. Because once you cite the original IPD as it was, it cannot, it limits, let me put that way, it limits the overuse or using it for other reasons except than, building the science knowledge.
Okay, thanks, Dudu. So Rob, now I'm just going to hand over to you for your closing remarks and to close the webinar. Over.
Great, thanks, Sharon. And I hope everyone who's on the call here today will agree with me that, some fantastic presentations there. And I'm not going to summarize everything that was said, but I think the first thing is that, I've been working in this area for nearly 20 years, and we've gone way, way beyond the, should we be sharing data? What we heard right at the beginning is that sharing data, it's not a question of whether we should or shouldn't, it's absolutely critical. And we're beginning to show that certainly during the COVID-19 outbreak, and from, say, WHO's perspective, it's been more than critical in informing the creation of new guidelines and having access to data really quickly. And actually, in relation to what the question that Dudu was just answering, transparency is key. So if we have access to the underlying data, we can really get behind whether the claims that are made within a preprint or a published paper are genuine, because we have all the pieces at our disposal. So that's really important. And that's why WHO and many others consider the sharing of data as a global public good. And we've made a number of statements on that. We also heard how the importance of building capacity, and that actually I think researchers sometimes feel a little bit lost about how to share data. So I would reiterate what Piak Jung was talking about, which is the training resources that are out there. And I would strongly recommend that if people haven't looked at the Global Health Network and the training center that they should, because the courses are free to access and use, and they are exceptionally high quality. And so that's one way that we can perhaps overcome some of the barriers within researchers themselves about, okay, I want to share my data, but how do I do this? And that's one way to do it. Again, I think improving our consent processes and making clear that the consent that we provide has a broad broad use and reuse, and that it's very clear that that doesn't mean unrestricted use. It means it's within a governance framework that's very clearly explained, and it protects the rights of individuals and protects their privacy, and that's really upfront and center. But what we see, and we heard say from the EDO example, is that there are many mechanisms now that enable that to happen in efficient ways and effective ways. And that's what we want. We want things to be effective and ethical and have an impact. And what we see with EDO and other systems is that there are ways to do this. So we've gone way beyond the problems of data sharing, and we are now in the area of this is able to be done, and we need to be able to do it because it's a critical tool in public health, and it's certainly a critical tool in when we're facing something like a global pandemic. So an example there that we heard was making linkages between the depositors who deposit their data and the reusers, and the use of things like a DOI, a specific identifying number, so that the depositor gets the credit and the attribution when their data is used by others, but also they have the opportunity to be part of the collaboration moving forward. And again, I think this is a fantastic mechanism, particularly say in the past, there was an inequity of data sharing, particularly data coming from, say, low resource settings, which was being used perhaps in high income countries without the attribution. And that, you know, we have this kind of inequity of use. We now have mechanisms to address that, and I think that's exceptionally good. And in the last presentation from Dudu, what we are hearing is we have to go beyond just policies and statements. We actually have to monitor them and evaluate them and then take action to improve them. It's not good enough just to put out a statement. And so what we see within the clinical trials that are registered is a huge variation between platforms, but the platforms are only mirrors. They just mirror what's being out there. And so we have to have a look behind, you know, why is it we're getting such excellent response from the Pan-African Clinical Trial Registry? You know, that 90% of those registered trials say, yes, we want to share the data. And why are we so poor in high income countries where 50% are actually saying they will not share the data? So there's something to explore as we go further. And finally, I would say what this suggests to me as we move forward is we have the technical solutions to share data. We have the training resources to enable people to share data. We understand how to do it in ethical mechanisms. What we now need is for all the stakeholders, funders, sponsors, journals, health agencies, to work together to ensure that the policies that they have in place, and the ones that they all put forward, are actually being implemented on the ground. And where they're not being implemented, what is we need to do to nudge and move things forward? Because as you know, returning to the very first point that was made, sharing data is a critical tool in the public health toolkit. We can't just not allow that to happen. And so we need to move that forward. And I think there's a role there for all of those different stakeholders to not just state that data sharing is a public good, but actually do something about it. And we've heard today the different mechanisms that exist that will enable them to do that. Thanks, Sharon.
Thanks, Rob, for that great set of closing remarks and sort of rounding up everything and summarizing it. So we're just 3 minutes over the hour. I'd just like to, again, thank all the speakers for wonderful presentations, to thank Rob for a great closing statement, and also to thank everybody for attending this webinar, for some excellent questions. And please, if you're interested to become a COVID-19 Clinical Research Coalition member, or if you would like to apply to join the data sharing working group, these are the QR codes that you can use. And you know, it's great to have you come with us on this journey. So once again, thank you everybody for coming on to us today, and thank you for your participation. And there's a survey that we'd be very grateful if you could fill out after this webinar. So wherever you are in the world today, again, good morning, good afternoon, and good evening. And hopefully we'll see you all soon some other time. Bye.
Thanks, Sharon.
Bye. Bye, everyone. Thank you.
Bye-bye.